The following podcast is part of a certified educational activity titled Mastering the Use of Dual Antiplatelet Therapy for Preventing Recurrent Stroke. How well do your current strategies match with the experts? Access the entire activity and complete the post-test at peerview.com/SPE860. Downloadable slides and practice aids are also available.
Welcome to Mastering the Use of Dual Antiplatelet Therapy for Preventing Recurrent Stroke. How well do your current strategies match with the experts? I'm Greg Albers from the Stanford Stroke Center, and I'm very pleased to be joined by Clay Johnston from the Dell Medical School at the University of Texas in Austin. We will be your panelists. All right, again, welcome. It's great to have you here. Clay and I are very excited to be here with you tonight, whether you're joining us live from New Orleans or if you're attending virtually. I'll get us started with a brief introduction, and then I'll turn things over to Clay, who's going to talk about the current evidence for dual antiplatelet therapy for secondary stroke prevention. And just as a reminder, look out for polling questions during the presentations. We're going to be talking about TIA and minor stroke and the recurrent stroke risk that occurs after those events. We group those together because they're both common conditions and they're both associated with a high risk of early recurrence of ischemic stroke. As you can see from the slide, these are very common conditions, and these are patients who are likely to have a new active thrombus. And because of that, the risk of early recurrence is high. And we've known this for many years. This is a landmark study from Clay, which was published in JAMA more than 20 years ago. It shows that these patients who have a TIA or a minor stroke have a very high early recurrence risk, particularly over the first days to week. Substantial risk of an ischemic stroke, but that risk continues on for years after the event. Now, if we talk about mild stroke, it's really not as mild as it sounds. First of all, it's a common condition. If you look on the left at the Get With the Guidelines registry, you can see there's a large number of patients who present with low NIH stroke scales, 5 or less. But if you follow these patients over a few months or even a year, what you can see is that the good outcome rates are not terrific. About a third of these patients will be disabled over the course of the next several months to year, and the mortality rate is on the order of 10%. What we're going to talk about tonight is evidence from the major trials. We'll talk about the guidelines, and we'll try to use this evidence to apply to a number of patients. And we'll look in detail about how the management of these patients is influenced by the results of these large randomized trials. The first patient is named Eleanor. She's an 85-year-old white woman who had the sudden onset of left-sided weakness while she was eating breakfast. A neighbor in her apartment building heard her call out, and after falling to the floor, and the neighbor called 911. Eleanor has hypertension. She takes an ACE inhibitor. She's on a statin for hyperlipidemia, and both her blood pressure and lipids are currently well controlled. Her laboratory studies are remarkable only for borderline anemia. And on exam in the hospital, 7 hours after onset, she had left-sided neglect and incomplete face, arm, and leg weakness. And her NIH stroke scale was 3, so it was very mild weakness. The CT reveals an infarct. All her large vessels appear patent on the CT angiogram. And the CT did not reveal an infarct, but the MRI did show a small acute infarct in the right frontal lobe. So, what antiplatelet therapy would you recommend for Eleanor? All right, we're going to move right into Masterclass 1, which is getting to know your options, a review of the current evidence for DAPT with P2Y12 inhibitors. And it's my pleasure to introduce Clay Johnston from the Dell Medical School at the University of Texas at Austin. Clay, take us through.
Thanks, Greg. It's a pleasure to be here, and I'm sorry we're not there together in New Orleans, but hopefully next year. So now I'm going to go through some of the evidence that I hope will help you to answer that Eleanor case with a little more confidence. So the recent trials now have been incorporated into the guidelines, both for the European Stroke Organization and also for the American Stroke, American Heart. I'm going to, rather than review these in detail, I'm going to go through the evidence behind them, and then Greg's going to return to these and talk about them, having reviewed all the evidence behind them. Now, what we're not talking much about is dual antiplatelet therapy in the long term. So when initiated, not in the acute period, but days to weeks to months after a TIA or stroke. There are multiple trials that have evaluated dual antiplatelet therapy in these settings. Here are the three biggest ones, the most important ones. All of these trials were negative. Dual antiplatelet therapy, when you don't initiate it right up front, it doesn't really work. And sometimes there's an associated risk of hemorrhage. I mean, there's always a risk of hemorrhage and sometimes of hemorrhagic stroke. So that is different when you initiate therapy acutely, and that's what we're going to focus on today, because that's where the newest evidence is. These are the big trials in this space. They go back to publication of 2013 of the CHANCE trial, all the way up to just recently the CHANCE 2 trial publication. So I'm going to start by reviewing the initial trials in this space of clopidogrel aspirin versus aspirin alone. So CHANCE and POINT were actually very, very similar trials. They were actually designed at the same time by the same people. So we worked together to put these trials together. Are double-blind, placebo-controlled, randomized trials, and they're asking the question: in patients with acute mild ischemic stroke or high-risk TIA, using ABCD squared score to define high risk, is clopidogrel with aspirin superior to aspirin alone in preventing subsequent stroke and ischemic events? And they're, again, because they were designed really at the same time, they're more similar than different in terms of their design. CHANCE used a smaller loading dose than POINT for clopidogrel, and it only treated with combination therapy for 21 days before moving on to single drug therapy, whereas POINT treated for a full 90 days of the combination. And then the entry criteria were quite similar. POINT required within 12 hours, CHANCE within 24, otherwise the same. And then the really important difference is that CHANCE was only in China, whereas POINT was international, not in China. That they did a wonderful job of getting things done quickly in China, but then it did raise questions about generalizability, and that took a while to resolve. So CHANCE. So I'm reviewing this stuff in just a small number of slides, so not much lead up. But bottom line, CHANCE was very positive. And again, this goes back to 2013, so almost a decade ago, we had evidence that dual antiplatelet therapy could work in the acute setting. And that separation occurred very early on, and it persisted for out through the 90-day period. Ends up in later analyses that 21 days captured the most of really all of the benefit of the combination. Of course, that's for their trial when both drugs were being used together. And it was also safe in CHANCE, that combination. There were more sort of mild bleeds, at least trending towards more mild bleeds in the clopidogrel aspirin group. But for severe and moderate bleeds, they did not see an increase. And that was a surprise. So then later, POINT came along. So actually, POINT was started before CHANCE, but the Tianten group in China and the Chinese are just amazing trialists, and they were able to get it done incredibly quickly. It took us a lot longer. So it didn't come out until 2018. But similar findings in terms of efficacy, a separation early on that persisted throughout the 90-day treatment course. Outcome was major ischemic events, which included ischemic stroke, MI, and ischemic vascular death. Major hemorrhage was increased, though, in point, and that hadn't been seen in chance, with more than a doubling in risk, although the absolute risk was quite small. So here, the y-axis is exaggerated here to 10%, not 100%. It's a 0.5% difference. So it's a small risk, but it's real. Most of those were GI hemorrhages. A predefined analysis from point was to look at the 0 to 30 days versus the 31 to 90 days. And the 0 to 30 days really captured the benefit of dual antiplatelet therapy. And then a secondary analysis, the optimal duration of treatment was actually 21 days. So consistent with what Chance had seen. So it may make more sense just, again, it's always got to be careful cutting data after a randomized trial was done, but at least it suggests that most of that benefit, if really not all, is occurring in the early period, whereas that hemorrhage risk is spread out throughout the time in which people are treated with dual antiplatelet therapy. Okay, so bottom line on that, and starting on the left here, is that clopidogrel and aspirin, it works for this, in this acute setting. And it's pretty safe compared with aspirin alone. And meta-analysis, yes, there's an increased risk of bleeding, but not mostly reversible bleeding. GI bleeds, and so look pretty good. And that's a pretty big treatment effect. 25% risk reduction, pretty good. So that's the clopidogrel and aspirin data. Next was this notion that maybe ticagrelor would work better because it has greater consistency in effect. And Greg's going to talk some more about this later in terms of the differences between ticagrelor and clopidogrel. But given that the possibility that ticagrelor might work better, we studied ticagrelor versus aspirin alone. Let me just show you how that went. I mean, I think a lot of you know this. That was the Socrates Trial, and that was published in 2016. And that was a very large trial, international. We initiated treatment within 24 hours after symptom onset and continued that treatment for 90 days. And again, it's ticagrelor alone versus aspirin alone. And the question was, is it useful in reducing stroke, death, MI? And as you can see from the results, it did appear like the ticagrelor would be superior, but in fact it's not. The hazard ratio is 0.89 and the p-value 0.067. So, maybe it was close, but no close in clinical trials. So we didn't have evidence that ticagrelor was superior to aspirin in this group. Happily, it didn't produce more hemorrhage anyway. So at least reassuring, but again, not so relevant when you don't have evidence that it actually works. And then we had known that we were going to look carefully at the patients who came in on aspirin. The reason was that, those who come in on aspirin, that aspirin's going to have an effect for a couple weeks afterwards because of its irreversible effect on platelets. And so those on aspirin, when they came in, when they're randomized to ticagrelor, effectively they're getting ticagrelor aspirin. And sure enough, that group did better compared to those that were randomized to continue on aspirin. And so given that, we went back to say, okay, gosh, maybe we should have studied dual antiplatelet therapy initially. Let's go back and study that now. And so that was the Talus Trial. So this was another gigantic trial, 11,000 patients, international treatment that began within 24 hours, just 30 days, trying to keep the trial simpler now, knowing that most of the effect was in that first 30 days. And we asked the question, in that same high-risk group of patients with minor stroke and TIA, is dual antiplatelet therapy with ticagrelor and aspirin superior to aspirin alone in preventing subsequent stroke or death. And in fact, it was. So, bottom line, hazard ratio of 0.83, again, that early separation that persisted out through the 30 days. So in a decent treatment effect, not quite as large as was seen in point in chance, but different population, different duration of treatment. So hard to make an indirect comparison. Most of that effect was in ischemic stroke. And remember, for point, it was all ischemic events. And so there, the hazard ratio was even more similar to what was seen in point, 0.79. But again, huge overlap in these as well. If there's been a lot of confusion about disability, I wish we hadn't done it this way. One of the secondary outcomes was just to look at the proportion of people with disability treated with ticagrelor versus placebo. But remember, a lot of these folks had disability from their index event, their index stroke. And so that ends up overwhelming any impact on disability from a new stroke. So when we looked at disability associated with a disabling stroke and just said, are there more disabling strokes in one group versus the other? In fact, there is an effect. So the ticagrelor aspirin does reduce disabling strokes. It doesn't reduce global disability, but again, there's a ton of noise in global disability in this population. And this just sort of lays out that effect occurs over a variety of different ways of defining disability based on the MRS score, modified Rankin scale, and that's it's pretty robust over a series of definitions of disability. Again, a secondary analysis, but just important to clarify, it's not that it's not impacting disabling strokes or disability associated with new strokes. It is, but you can't see an effect in global disability. There is definitely an increased risk of hemorrhage with ticagrelor aspirin compared to aspirin alone. The hazard ratio is almost 4, but the absolute size is pretty small. So 0.4% increase in hemorrhage. And whereas in point, most of those hemorrhages were GI, in Talus, most of those hemorrhages are intracranial or fatal bleeds, as you can see from this chart. And so, a little more worrisome that we're getting events that really do impact people. That being said, it's a 4-to-1 ratio of a reduction of ischemic events to increase in hemorrhagic events, probably similar impact of those in those two groups. So still risk-benefit favors treatment overall in the trial. Okay, so now back to Eleanor. So Greg described her already. She is this, the 85-year-old who came in with a minor stroke. And now back to the question: which antiplatelet treatment would you recommend for Eleanor? Greg, I think you're going to go through some of the details later about the differences between the two therapies. But what's your take on the Eleanor case or not? I mean, it's without getting into clopidogrel, ticagrelor, what's your feeling?
Yeah, well, clearly this is somebody we would jump on right away with dual antiplatelet therapy. She's got a minor stroke. She's come in very early after onset. She's not a candidate for thrombolysis or thrombectomy. So I'd be looking at a dual antiplatelet therapy over a short period of time, like 3 weeks, 4 weeks. And I'd also be evaluating her to make sure that we're not missing a cardiac source of emboli. Could she have paroxysmal atrial fibrillation? Because that obviously would change the longer term treatment. But for the short term, I think she's an ideal candidate for dual therapy. And she really fits in to be a typical patient from the studies that you just reviewed.
Yeah, good. Yeah, and I agree. And we should have let's just underline that, cardioembolic stroke, those patients were not included, presumed cardioembolic strokes were not included in any of those trials because we've got therapies for them, right? We've got anticoagulation, so right, therapy for that group, at least we know that for the AFib-associated events. And the other group too that's excluded is anybody who needs thrombolysis, and she's not that either. So yeah, dual antiplatelet therapies, start it ASAP, right? I mean, there's no reason to delay. The trials really would suggest if you're going to affect that curve, that steep curve, you're going to have to treat right away.
Yeah, so loading dose and then standard therapy for at least 3 weeks.
And then what do we have 2 different loading doses tested in trials, 600 and 300. I have my own, now I'm talking about Clopidogrel. I have my own biases about that, but what's your take? What do you guys do?
We typically do the 300. I think, some prefer 600, but as you say, 2 trials both had, similar positive results. What's your take?
Yeah, I mean, I'm partial to Point's way of doing it just because, the rationale for it was get the antiplatelet on board ASAP, and you can do that a little better, at least theoretically, with the 600. But I recognize that, patients look at that big pile of pills that you're trying to get them to take, and they're like, what? So, I understand. And we don't have real evidence that it made a difference in Point compared to chance. So back to the Eleanor case. So she was started on dual antiplatelet therapy right away, so awesome. But her daughter, a medical student, raises concerns about bleeding and polypharmacy. So Greg, how do you handle one of these pesky medical student family members?
Well, it's a great opportunity for education. It's always important for family members to understand the rationale for the treatments we're giving. And here with a medical student, there's even more opportunity to talk about why we have these different classes of medicines. Clearly, she's got multiple vascular risk factors, hypertension, her high cholesterol are going to be treated with separate medications. These medications are compatible with each other. And then probably what she's digging into is the fact that there's 2 medicines from the same class. Why are we giving 2 antiplatelets rather than 1? And you just illustrated it beautifully, that there is risk, but the benefit outweighs the risk. So we're particularly concerned about Eleanor having an early recurrent stroke. So we really want to hit the platelets hard with the dual antiplatelet therapy to try to get that thrombus calmed down. And we acknowledge the risk of bleeding, and there are going to be things that you can do to mitigate the risk. So I think we can probably get the medical student over the hump here and at least get 3 weeks of dual therapy. And realizing that it's a short-term risk of bleeding, it should also help reassure the student.
Yeah, so we're not talking about lifelong polypharmacy. We're talking about short-term polypharmacy. Although she's bought lifelong single antiplatelet therapy, of course, but that's simple. People are used to that. Okay, and then now the patient agrees to take all the prescribed medications, but then on day 7 of therapy, her crit is noted to be falling, and colonoscopy reveals a non-obstructive malignant lesion near the hepatic flexure. Okay, so now problems with bleeding. So Greg, how do you approach this?
Yeah, so the plot has clearly thickened here. It was interesting that she had some borderline anemia when she came in with the stroke, and probably this tumor has been responsible for that. And now it sounds like her bleeding has accelerated, possibly because of the dual antiplatelet therapy. So one of the important things to do is to figure out what's going to be the approach to this lesion. If there is going to be a surgery to resect part of the colon, I want to talk to the surgeon and see what they're comfortable with. In general, they would not be comfortable with dual antiplatelet therapy going into a surgery, so the decision would be whether we just stop it for a period of time, get that colon cancer taken care of, assuming it hasn't metastasized, and then go back to the therapy afterwards. And by that point, I'd probably just go back to the single therapy. We made it through the first week, which is the highest risk week with the dual therapy. And then by the time we get this tumor sorted out, I suspect we're going to be probably getting out close to the 21-day duration that I would be thinking of for dual therapy for this patient.
Great. Yeah, and I mean, I wouldn't be mad at dual antiplatelet therapy in this instance, right? It revealed a tumor. It actually served a fantastic function.
Absolutely. Yeah.
Yeah. So again, I think we tend to focus on, oh gosh, bleeding complication. Sometimes that's not a bad thing. In this case, it wasn't a bad thing. All right. So now another case. So this is Constance. So she's 87 years old, lives with her 62-year-old son, and noticed that she recently began favoring her left side and seems to have difficulty picking up small objects. And her son reports that she's had some strokes before and she has AFib. Doesn't use alcohol, tobacco. Lab studies are remarkable for elevated glucose. Her INR is 2.2, hemoglobin's 10. She's got AFib on her ECG. Blood pressure is just mildly elevated. She's on metformin, lisinopril, levothyroxine, omeprazole, rivastigmine, warfarin, and multivitamins. Mildly visually impaired, difficulty with some verbal instructions, NIH stroke scale score is 4. And then her CT shows a small infarct in the right parietal lobe, multiple old infarcts noted in the left and right cerebellum and cerebrum. So what do you think of this patient of Constance? Is she a candidate for antiplatelet therapy? And if so, which one?
Yeah, so this is a patient with multiple prior infarcts. She's got a presumably new acute or subacute infarct in the right parietal lobe to fit with her symptoms, where she's having trouble with her left side. She's on warfarin with a therapeutic INR. It's a little bit on the lower side, but still in the therapeutic range. So to answer the question, antiplatelet therapy would not be what I would be thinking about here. Some people would wonder, if I added the antiplatelet therapy to our warfarin, will I get more protection, since she seems to have had this stroke despite the warfarin. But in general, what the studies have shown is that strategy of adding antiplatelet on top of the warfarin for non-valvular AFib patients leads to more bleeding without more benefit. So one of the things I'm asking whenever I see a patient who's anticoagulated and has another stroke, if they're in the therapeutic range, is there another cause? Did they have a dissection? Is there intracranial athro? Is there vasculitis? Is there something else that's not going to respond to warfarin that might need to be treated differently? But assuming that all we have is the atrial fibrillation after evaluation, what I would be thinking about is switching the warfarin to a DOAC. There is certainly evidence that the DOACs are a bit more effective than warfarin. They're also much more convenient. So I think that's the way I would go, and I would stay away from adding an antiplatelet. How about you, Clay? Would you treat her any differently?
No, I would treat her just the way you described. That just makes sense. That maybe she was under anticoagulated at a prior point, and that set up the thrombus that now we're dealing with the consequences for. So I like the DOAC plan. And yeah, I wouldn't recommend adding an antiplatelet agent. I mean, occasionally we do that. I'm sure you do as well, add an aspirin to anticoagulation, but it always makes me uncomfortable knowing, the data is just not very strong, and definitely has an associated increased risk of hemorrhage. That brings me towards the end of my part of this presentation. I mean, I think the key takeaways from this part are, we got to get these folks, the high-risk TIAs, the minor ischemic strokes, we have to get them on dual antiplatelet therapy, preferably within 24 hours. We can talk about that later, whether it's ever okay to treat when you can't treat within the first 24 hours. But we got to do it, and we're not doing that right now consistently based on little pieces of data that I've seen. I think we're going to need to track it. and make us more accountable for it, but we're missing a lot of opportunity to prevent new events. You only need to treat for 21 to 30 days, I think. I'm totally comfortable with that, even though the trials weren't always done that way. The evidence collectively really suggests that's plenty of time. And then this choice of whether to use clopidogrel or ticagrelor is complicated. And it's so complicated that I'm inadequate to cover it, and I'm going to hand it over to the big gun, Greg Albers, to opine. So with that, over to you, Greg.
Thanks, Clay. Yeah, so we will talk about some of that complex data and see if we can sort through it the best we can. And just before we dive back into some data, let's go in a little bit more detail over these guidelines that Clay already introduced. If we start with the European stroke recommendations, you can see that both the aspirin clopidogrel combination from Point and Chance were recommended, as well as the option for ticagrelor and aspirin, as in the Talus study. And you can see these recommendations reflect the inclusion criteria for the study. So Point and Chance, we're looking at the lower NIH stroke scale, 3 or less for the minor stroke, whereas in the ticagrelor studies, they were going up a little bit more towards the mild to moderate, getting up to an NIH of 5 or less. You can also see there's a little bit of difference in the ABCD2 scores for the TIA patients between the trials. But fairly overlapping population, and basically they're giving you a couple of choices. The ASA-AHA recommendations on the right, not too dissimilar. They rank the treatments with the standard HA levels. And you can see, because there is more substantial data from the trials on aspirin plus clopidogrel, we have more trials, more data. It's getting the level 1A recommendation. And again, here they're going on to the 21 to 90 days. And I think most stroke neurologists like Clay are on the 21-day side of that. And for the reasons that Clay reviewed very nicely. So there's a nice recommendation there for these patients, and NIH score less than 3. They've got an ABCD squared of 4 or more if they're a TIA patient, to use that combination. And then for a level 2B, we have the similar recommendation for the ticagrelor plus aspirin. Here they go for the 30 days, which was the trial duration there for the Talus trial. And as mentioned, you can pop up to the little bit higher NIH per the inclusion criteria of that study. All right, so let's dig a little bit deeper into the differences between these agents and the one head-to-head large randomized trial that was performed comparing clopidogrel aspirin to ticagrelor aspirin. So first of all, if you can see here that one of the main differences is that clopidogrel is a prodrug, which means it has to be metabolized by the liver. And as you're aware, there's variable liver metabolism, with some people being faster metabolizers, some people being normal, and some people being slower metabolizers. So that can lead to different activity of the clopidogrel in different patient populations. Ticagrelor, it is an active drug which doesn't require that liver metabolism for it to do its work. You see the dosing, as we talked about, there's 2 different loading doses used in the clopidogrel aspirin trials. So that's dealer's choice there, and then 75 milligrams a day. Whereas the ticagrelor trial was the loading of 180 and then followed by 90 twice a day. So one is a twice a day drug and one is a once a day. So if that's important, there's a difference there. You can see half-lives are slightly different between the drugs, but there's a lot of similarity as well as the differences here. Now, in terms of the CYP2C19, that's going to be the key area for these loss of function alleles, because this is what is going to activate that clopidogrel. And you can see that nothing is simple, and here it's not so simple as that you're a good metabolizer or a bad metabolizer. Most of the patients, you can see in the center of the trial, of the slide here, most of them are normal metabolizers, but that's going to depend a little bit on your racial background, because particularly the Chinese, in particular the Han Chinese, have a much higher incidence of people having this intermediate to poor metabolizer state. And that means you're either carrying one of the loss of function alleles, or a small percentage actually carry both of the loss of function alleles. So you can see there's a wide range of efficiency of metabolizing clopidogrel. So does it matter? That's been a debate for many years. How much does it matter if you're one of these patients who's got a loss of function allele for the CYP2C19? Does clopidogrel still work for you? And this is just to demonstrate where the metabolism is occurring. There's multiple enzymes, but the CYP2C19 is critical. It activates the clopidogrel, so it can then inhibit the P2Y12 receptor, whereas for ticagrelor, it's a direct effect. So some of the more substantial data that we have in the stroke field came from this sub-study of the CHANCE trial, which was published in JAMA way back in 2016. So we've known this for several years. And what we're looking at is that this was a Chinese trial. So there were a number of patients who had carriers of one of the loss of function alleles. And if you look at them down at the bottom, you can see that the carriers in red did not do nearly as well as the non-carriers. So if you were a normal metabolizer of clopidogrel, your stroke rates in the CHANCE trial were substantially lower than if you carried one of the alleles. And in fact, if you carried one of those loss of function alleles, you were similar to aspirin results. In fact, it wasn't statistically different from aspirin for that group of patients, whereas if you were a non-carrier, you can see this as a very dramatic benefit from aspirin. So this was suggesting, yes, that the genetic variability does make a difference in the response to clopidogrel. They also did notice in this trial that if you were somebody who was carrying one of these loss of function alleles, you didn't have as much bleeding, which makes sense, right? You're not activating the drug, you're not getting as much efficacy, but you're also not getting as much of the bleeding. And this is the biggest trial, the one I just showed you out of CHANCE, to look at this issue. But you can see there's a whole range of other trials, many of them from China. They're smaller, but when you add them all together in this meta-analysis, you can see that there's really little question that if you're carrying a loss of function allele, that your stroke risk on clopidogrel is higher than if you are not, if you're a normal metabolizer. So as we've already mentioned, ticagrelor bypasses that liver metabolism. It can directly inhibit the P2Y2 receptor, so you don't have to worry about, are they a fast or slow metabolizer. So the head-to-head trial to try to really drill down on, the question, does it matter, is the CHANCE-2 trial. And this is one that just was published a few months ago in the New England Journal. So let's take a look at what the CHANCE-2 study did. Again, a large number of patients, over 6,202 sites in China. So that way you're going to have the opportunity to find patients who have a loss of function allele, and that's who was enrolled in this trial. So this trial was unique in that it only enrolled patients who had were poor metabolizers of clopidogrel. So you would anticipate that the ticagrelor plus aspirin would likely be more effective than the clopidogrel plus aspirin if you believe this loss of function allele really makes a difference. And lo and behold, it did make a difference. And the benefit here was quite convincing. You can see a p-value with a couple of zeros after the decimal point. And the absolute benefit here was really comparable to the benefit that we saw in the trials that Clay reviewed between dual versus aspirin. Dual versus single had a similar benefit to what we saw here. Again, over a 20% risk reduction, so a substantial benefit to these patients who had the loss of function allele to be on the ticagrelor aspirin versus clopidogrel aspirin. That's in terms of efficacy preventing stroke. What about the downsides? Bleeding. And again, you might expect a little bit more bleeding here because you've got people who are not metabolizing the clopidogrel as well, and then you're comparing to full effect ticagrelor plus aspirin. And interestingly, we really did not see the bleeding concern here. If you look at the type of bleeds that you would worry about, intracranial hemorrhages, fatal bleeds, severe and moderate bleeding, really no difference at all. You do see a difference in the mild category. You can see there 5% with mild versus 2.2. So there certainly is evidence that there is more bleeding effect here in patients who are having the ticagrelor effect compared to patients who are clearly having a bit of a blunted effect from the clopidogrel because of their metabolism status. So that brings us to our next patient, who's ZHANG. And this is a 65-year-old Asian male, happens to be Han Chinese, and has had sudden onset right-sided weakness, difficulty finding words while he's walking with his wife. His wife calls 911, but the symptoms resolve by the time he gets to the hospital. He's got some vascular risk factors, hypertension and diabetes. He's on appropriate medications for those, although he does have a little bit of an elevated glucose and hemoglobin A1C on his labs. An hour after onset, he's completely normal. In the ER, he's got an ABCD score, which is 5. CT, it doesn't show an infarct, and all large vessels appear patent on a CT angiogram. ECG looks fine. So Clay, question for ZHANG. What antiplatelet therapy would you recommend for him?
Yeah, so first of all, the key is that he needs to be on dual antiplatelet therapy. So, we're catching him early. He's a high-risk TIA, so he needs to be on dual antiplatelet therapy. And then the second question is which combination? And, you nicely showed, I think, the most important data on this. So Han Chinese, so the likelihood that he's a poor metabolizer of clopidogrel is actually more than 50%. So, I think I would feel a little uncomfortable giving him something that may not work for him. Probably can't get a genetic test right away. So my choice would be ticagrelor and aspirin. We with chance 2, we have head-to-head data, at least in those that don't metabolize. And, again, more likely than not, he doesn't metabolize. And then we can fall back to indirect comparisons to say, well, it's a fine choice overall anyway.
Yeah, I agree. And so did the physician who was treating ZHANG, because he was started promptly on ticagrelor with a loading dose and aspirin for a planned 30-day course. But all plans don't always come out the way we plan, because a week later, he's calling and complaining of dyspnea. So the question is, how are you going to handle that? Are you going to stop the medication? What do you do when they call back and are having some dyspnea on ticagrelor?
Yeah. So this is a known issue with ticagrelor. So obviously it could be something else. So, you want to be thinking about, could it be another cause? But it's actually fairly common with ticagrelor. We were concerned about it going into Socrates and Talus. It was very infrequent in Socrates and Talus. It's been more frequent in cardiac trials, probably because those patients are more attuned to, any change in breathing than our stroke patients are. But it very rarely led to discontinuation of therapy. And the approach that we took was just to reassure folks, and generally goes away after, it's just a sensation, goes away after 2-3 days. It's an adenosine effect. So it has nothing to do with, pulmonary function or, fluid in the lung, anything like that. It doesn't make heart failure, nothing. It's just a direct adenosine effect. And it's producing the sensation.
Yeah, absolutely. So both in Socrates and in Talus, although we were concerned about it, it really did not turn out to be a big issue. But it is certainly important for physicians to be aware of this. And as you said, the cardiac docs are more in tune to this because it was more common in their trials. And certainly for them, the constant question is this the drug, or is this their underlying cardiopulmonary disease, which is flaring up? So this is an algorithm that has been adapted from a cardiac article in European Heart, which gives physicians some advice on how to do this. And it just follows exactly what you said. First question is, can I eliminate other problems? Are they going into congestive heart failure? Do they have a pulmonary problem? And if you don't find any evidence of that, then you start thinking this could be ticagrelor related dyspnea, and you want to see how long is it going to last. So, oftentimes it's going to just go away on its own with reassurance over a few days. If it's still there a few days later, then you have to really ask, is the patient able to tolerate it with the reassurance, or are they just really feeling uncomfortable? If they're quite uncomfortable, then you could consider switching to an alternative antiplatelet agent. But in most situations with the ticagrelor related, you're going to be looking at just a few days to a week for this to disappear. So again, not a big issue in our stroke population, but certainly something that physicians need to be aware of so they can handle the phone calls. All right, so how to decide? Clay, you did a great job of summing up some of the pros and cons. I mean, clopidogrel, we have a larger database at this point and slightly stronger recommendations from the American Heart Association based on that. It's out as a generic drug. It's less expensive. It's once a day. Ticagrelor, big advantage is for these people who you're worried about having a loss of function allele because you don't have the genetic variability. The trials included slightly more moderate stroke severity, so you might think about that if you've got somebody who didn't quite meet the minor stroke criteria for point or chance, and it does have an FDA approval for stroke prevention. So let's jump into another patient. This is Hugo. He's a 72-year-old Hispanic man. He's been diagnosed with a left hemisphere TIA a couple of weeks ago. He was started on clopidogrel and aspirin, very quickly after those TIAs, the planned 21-day course. But today he has a similar episode, so another TIA-like episode. Sounds like a left hemisphere event with receptive and expressive language dysfunction and some right-sided body numbness that lasts 15 minutes. He comes into urgent care. He's got hypertension. He says he's been compliant with his ACE inhibitor as well as the clopidogrel aspirin combination. His lab studies look good, and he's got an ABCD score, squared score of 4. So one of the questions, Clay, is would you test this guy to see maybe he's, clopidogrel refractory based on the fact that he's continuing to have TIAs while on clopidogrel aspirin?
Well, it does make me wonder. Presumably we don't know. He's Hispanic, so his risk could be of having, of being a poor metabolizer for clopidogrel could be about 25-30%. So he's certainly at risk for not being a metabolizer. I'm curious, if it's easy to get that genetic test, then yeah, it'd be nice to have it. Not too expensive. I'd like to know.
Yeah, and that's one of the issues. What we've been told by our hematology folks at Stanford is very shortly we're going to have a point of care, quick turnaround test, which I think would be really helpful for Hugo so that we could know. Right now it's a send out and it's going to take several days to come back, and really you want to make a decision today. But as we talked before, when somebody is having recurrent events, it's always really important to think, is there anything else that can be going on, anything else other than just some atherosclerosis? Could there be a cardiac source? Could there be dissection, other condition, drug abuse, et cetera, that could be playing a role? So, thinking about a full evaluation when somebody's now had, 3 events over a short period of time. All right, that's great. So let's now look at the key takeaways from this section. What we've emphasized that these CYP2C19 loss of function alleles do occur. They occur with different frequencies in different populations of individuals, so we need to be aware of that. You can test for these, or you can make an assumption, as Clay did for our Han Chinese patient, that he likely does have one of these loss of function alleles, and that could be a strong argument to go with ticagrelor in that situation. If you're looking at somebody who is very limited financially, we have a drug that's off patent versus one that's on, so there's price differences. One drug is twice a day, one is once a day, so again, that can be important to some people, although most of our patients had other medical conditions and were taking medications more than once a day. Let's now jump on to our third masterclass, and then we'll be looking forward to taking your questions. And here we're going to talk a little bit about patient-centered strategies to improve adherence. And I think Clay mentioned earlier that sometimes patients are not taking these medications that we've prescribed, and oftentimes we assume they are. And maybe if we explain it more clearly and have a more patient-centered discussion, we could increase the chance that these patients are really taking their medication. So the recommendations indicate that we should individualize therapy. Just as we discussed, there are patient-specific factors, there's cost, there's tolerance of the agents, there's the efficacy that we've been discussing, as well as other clinical characteristics to take in mind. And then we should think about how we're going to communicate why we're using two agents and why we chose the agents that we did. So we call this shared decision-making, and I think everybody has learned about this in medical school, but putting it into practice sometimes is a little more challenging. You can see this physician is having a lot of questions about, how do I do this? Do I have time to do this? Is this really going to make a difference? And there certainly is evidence that it does make a difference, that if you can really get the patient on board with helping to share the decision, and then they're behind it and more likely to carry it out. So there are many barriers. Some healthcare folks like to really be more paternalistic. They don't want to have a challenge to their autonomy. They sometimes don't enjoy making detailed discussions with patients where the patients are bringing up of concerns or challenging the physician's judgment. And time plays a big role, right? Everybody would love to have more time to explain things in more detail to the patient, but when there's a full waiting room, we don't always have that time. The patients often would like to participate, but they're afraid that they can't understand the terminology, that if we're not speaking at the patient level, they can get confused, and they don't want to embarrass themselves by asking what they think are maybe not smart questions. There's also decision aids that could help with this, where the patient could learn about this before they discuss it with the physician, or read about it and then talk in more detail in a more educated manner at the next clinic visit. But oftentimes these decision aids are not available. So one of the key issues is time. You have to set aside time, because it takes a while to be able to figure out what's the patient perspective, what are their concerns, and what are their beliefs about these type of medications and medications in general. Oftentimes we assume that the patient understands when we give a nice clear explanation, but then when you come back later and you ask, what did you understand? It's often only a fraction of what we thought we taught. And one of the more common reasons that we see patients in our outpatient stroke clinic at Stanford is they had a stroke somewhere, and they left the hospital really having no idea why they had the stroke, either because it wasn't well explained or because they weren't in a position to really understand that explanation. They're still very distressed. They've had a stroke, and they're just coming back and hearing in a calm setting what's happened, why it's happened, and what are the choices. This is an interesting study from Journal of Neuroscience Nursing, where they're asking people from different cultural backgrounds what they think about medications. And if you read through these, you can see that it is, very, very different. Some people think medications are a panacea, and if you miss one, you're in huge trouble. Other people are very skeptical. They think medicines in general do more harm than good. Some think they're poison. Some think that every medicine is addictive. So there's a lot of misconceptions that different patients have, and it's really important to try to figure out what those are, to be able to explain to the patient why this medicine is really the right choice for them, and that it will do more benefit than harm. So this is a tool, and there are more information about this tool and some of the other things that we've discussed today that are available in the downloadable practice aid, which is part of this program. But this is just something you can give the patient, and you can click off these boxes to try to see, how many of these boxes did the patient feel had been checked in their visit. And in the ideal scenario, we hope that we check all of them. In reality, probably it's rare that we get all 9 of these checked off. And if you read through these, you could see that these are really the foundation of this shared decision making that would be most desirable. So worth trying this out on a few patients to see how good a job we're doing in terms of the patient's assessment of what they heard from us and how well they understood the rationale for the treatments that we recommended. All right, let's jump into another case. This is Andrew, 68-year-old man. He's living in a homeless shelter. He wakes up with left-sided weakness and numbness. He comes into the local ER a day later. He's got uncontrolled hypertension, but he's not taking any medications. He does smoke 2 to 3 packs of cigarettes a day. He's denying alcohol use. His labs show that he's got an elevated LDL. He's got some mild liver function elevations. His creatinine is not perfect. His EKG shows left ventricular hypertrophy. His blood pressure is higher than we would like at 158/96. On exam, he's got evidence that he's had a small stroke with left-sided face and arm weakness that's been there for now more than 24 hours. And he's got evidence clearly on his CT that there's a subacute infarct in his right frontal parietal region. And he's got some atherosclerosis being visualized in his intracranial vessels and an old infarct in the right cerebellum. So Clay, what are you going to recommend for Andrew?
Yeah, so for me, I certainly wouldn't recommend anticoagulation in someone like this, but antiplatelet therapy I would definitely recommend. He meets the criteria for dual antiplatelet therapy. And in this case, I'd probably favor clopidogrel because it's going to be easier for him to deal with. I'm sure it's going to be make it easier for him to get it. Maybe we can even discharge him with it, and also the QD benefits too are there. So that's what I'd recommend.
Yeah. So what if he says, "Well, look, I don't have any money. I can't pay for this."
Yeah, I mean, honestly, the key is to get him that medicine right at the beginning, right? So the separation occurs right away. The risk is greatest right away. So we can get him started on the meds for sure in the hospital. And man, this is where I would bend over backwards to get him the supply that he needs, 21 days worth. He's going to be discharged on 20 pills. Oh, come on, $1 a pill. That I think the safety net system, whatever it is locally, should be able to cover that, as opposed to the much higher costs associated with him being rehospitalized. And yeah, the initial cost effectiveness analyses in this setting suggest that these treatments are cost saving. So, it just makes sense from a societal perspective to get him on it. Now, whether I'll take it or not, it's another question.
Yeah, somehow he's finding enough money to buy a couple of packs of cigarettes a day, which are clearly more expensive than, if we really choose, hydrochlorothiazide or some very inexpensive antihypertensive, hopefully we can get him on that, since obviously he's got LVH, he's got chronic hypertension. So that's a big impact on recurrent stroke risk. That would be nice to get that under control. And then hopefully for the long run, he can, default to maybe just an aspirin a day, which again, very inexpensive in the long run once he gets through that, 3-week period where you're going to hand him the pills of clopidogrel. Great. And clearly, getting him to understand that the best we can, that although he's had minor events to date, that what we're really worried about is he's going to come into the ER with the big left MCA occlusion and leave him, disabled for the rest of his life. So trying to understand the gravity of the matter and see if we can get him on board that this is a big warning that, you want to get things together to avoid the bad outcome. Let's talk about Marlene. This is our last patient. She's a 71-year-old woman, recently widowed. She lives alone. She began feeling vertiginous. She wakes up 2 days ago, and then she's got an episode of diplopia, which lasts later, 20 minutes later in the day, when she woke up with a vertigo. She didn't come in until a couple days later. That's when She was able to get an appointment in the office. She had a minor stroke 4 years ago. She doesn't drink or smoke. Laboratories look okay, except her glucose is a little bit high. She's got some irregular heart rate, but it's not AFib. She's a sinus rhythm. Her blood pressure is 131/77. She's on antihypertensives, a statin, and she's on baby aspirin. She's got some evidence of posterior circulation trouble with an unsteady gait. And she, in fact, does have 2 small subacute infarcts in the left cerebellum and the left occipital lobe. And there's an old infarct on the right side as well in the cerebellum. Her NIH stroke score scale is 3. All right, last case, Clay. How would you advise Marlene?
Yeah, so this one's a little tricky, right? So she would not have been enrolled in any of the trials. They all required the event to have occurred within 24 hours. But her risk of recurrence is still quite high. And we did look at this in modeling. We haven't done this yet in Talus, but we did do this for Chance did it and Point did it. That you can expect that the benefit will persist, will be there, even for treatment out to 3 days after the initial event, just by modeling, how those curves separate. So I would be inclined to go ahead and recommend dual antiplatelet therapy for her. She's already coming in on an aspirin. That makes me even a little more uncomfortable just saying, oh, keep on the aspirin. And I don't believe that, clopidogrel alone is any better, even somebody who's been previously on aspirin. So I would just go ahead and put her on dual antiplatelet therapy. And I don't think it matters too much which of the 2 combinations you use in her. And I think I'd discuss that and understand her a little better before making a recommendation.
Yeah, that sounds great. One thing we've seen in multiple studies is that if you're taking aspirin and you have an event, that identifies you as an even higher risk person than if you had your event not on any antiplatelet therapy. So I'm seeing her as a high-risk patient. She's obviously got some older infarcts as well as these new ones. So I would agree that it's too bad we couldn't get the advantage of trying to prevent events in the first couple of days because she came in late. But certainly, as you've shown in multiple studies, the whole first week is a higher risk week. So I would agree going with the 21-day course of the double therapy and then working as hard as possible on her risk factors as well. Terrific. Well, we do have a little bit more information about what happened with Marlene. Antiplatelet therapy was recommended, but what she's telling you is that after her first stroke, she was on antiplatelet therapy and she cut her hand while she was cooking and she bled all over the place. So now that you want to put her on double antiplatelet therapy, she's really concerned that she's at high risk for bleeding because of what happened before, and can't we just get by with one agent rather than 2? So how would you respond to that concern?
Yeah, the risk is just too high, and we're talking about a short period of time. So I would reassure her and tell her, this is not a big risk. It's not a 0 risk, but it's not a big risk, and that it's in her best interest to just be careful. But just for 3 weeks, she can do this, and it could have an impact for the rest of her life. So that would be my approach, is to sort of work with her.
You'd also give her an opportunity to say, hey, I can't do the cooking for the next few weeks here. Somebody else has got to handle the sharp knives. But absolutely agree that people can be aware of the fact that there's a little bit of an increase in bleeding when they see the numbers from the trials. These are really not frightening numbers in terms of the risks of major bleeds. So I think some of what we talked about in that last session of really getting into understanding where this fear is coming from and trying to get other family members to be supportive of the decision, to encourage her that in this high-risk period, we really don't want her to have a stroke, and the chance of a stroke is so much higher than her having blood everywhere from another cooking accident. All right, that brings us really to the end of our program. The key takeaways from this last section is that shared decision-making can improve adherence to therapy, and it can improve patient satisfaction. It also begins with a supportive, non-judgmental, unbiased conversation with the patient, and it can be tailored depending on whether the greatest need is knowledge, skills, or reinforcement of positive behaviors. So that brings us to the end of our formal presentations.
Thank you, Dr. Albers and Dr. Johnston, for an excellent series of presentations. We have an equally excellent collection of questions from both folks here in person as well as the virtual attendees. So Dr. Albers, I'll get it back to you. I know you have some questions that we've sent to you. If you want to go ahead and get started with our Q&A session, we can get some of these answers out to the audience.
Yeah, absolutely. And we did get some fantastic questions. Some of the questions that came in, I think were handled pretty well through the presentation, but a number of them were not. So Clay, let's start off with this first question, which just says, when should antiplatelet therapy be restarted if the patient has an ischemic stroke and there's hemorrhagic conversion? What's your recommendation then?
Yeah, so, well, the recommendation, first of all, is to get someone on antiplatelet therapy in a situation like that at some point. So, and the trials support that folks who've had a bleed, even an intracranial bleed on antiplatelet therapy should be put back on it in real trials. But we don't have real trials that tell us about timing, the question here. And so it's really, a judgment call. Is it a week? Is it 2 weeks? It probably doesn't need to be longer than 2 weeks. And, how do I make it personally? I'd be curious to hear what you do, Greg, but, typically we wait, for just little petechial hemorrhages, we're not so worried and start it before a patient's discharged to make sure it gets started. And then for those with, real hemorrhagic conversion that causes mass effect, then we would wait a couple weeks for those kinds of patients.
Absolutely. We look at the type of hemorrhagic transformation that we're talking about because we think of these mild petechial hemorrhages as part of the normal evolution of virtually every stroke that's of a significant size. So we're comfortable starting the antiplatelet therapy with those mild petechial hemorrhages, but when you start to get into a PH1 or PH2 hematoma, obviously that's a different situation where we're going to hold off for at least a couple of weeks. And then again, we're looking at risk versus benefit. Is this really a high-risk patient versus a lower-risk patient? But we don't have great clinical trial dates, so you have to use your judgment weighing the risk of hemorrhage versus the risk of a recurrent ischemic event. You want to pick the next question, Clay?
Yeah, sure. So this one could almost be a trick question. Is dual antiplatelet therapy indicated in a stroke with only or predominantly sensory symptoms?
Yeah, so we reviewed the trial inclusion criteria, and I guess the question is it a stroke or is it just a TIA with sensory symptoms?
That's it, yeah.
And what is the NIH stroke scale associated with that? Because we had different rules for the different trials, but we were looking at NIH stroke scales of 3 in the Clopidogrel trials or 5 in the ticagrelor. ABCD squared, we needed 4 to 6, depending on the trial. So what I'm hearing here is probably someone who didn't quite make the criteria for the studies, so wouldn't have been enrolled. But then the question is, are there other features that really make you think this is a high-risk patient? And there's a subsequent question that how closely do you follow these rules, right? With, if it's a score of 4, they wouldn't have made it into point or chance. But would you still be comfortable with clopidogrel? And Clay, as somebody who ran these trials, how strictly in your clinical practice are you following the rules that you used in the trials?
Yeah, not so strictly. Really, the ABCD squared score was designed to identify people who had a real event. And so if you really believe the patient had a real transient ischemic event in the brain, then that's a high-risk patient. I mean, that's really my take on it. And it does work better, though, than our judgment. So I'll just say that. Our judgment's not particularly good about whether an event was really a TIA or not. So the score is useful. In this case, if the patient has infarct, then use the AHA definition the trials did. That's a stroke. ABCD squared score is irrelevant. If it's sensory-only symptoms, they're still a candidate for the trial.
Terrific. Let me combine two questions into one. These are questions about how to handle patients who are on their way to endarterectomy or carotid stenting. So one of them is, if you think you're going to be heading quickly to endarterectomy, do you go ahead and load up with the dual antiplatelet therapy because the surgeon might not be thrilled about that? And secondly is, after they've come back, they've had their successful endarterectomy, but they're still within the 21 days after their event. Are you going to still go with the dual therapy now that presumably the guilty party has been removed?
And these are great questions. We struggled with these for the trials too, because as you can imagine, this would really matter for some patients in the trials. And basically where we came down is many surgeons are comfortable doing surgery on both drugs. So find out whether your vascular surgeon is one of those surgeons. For stenting, they should be on both drugs. I mean, everybody wants them on dual antiplatelet therapy, so that makes that easy if that's the choice. And then, how long should they be off before surgery is done? Again, it's surgeon dependent, and it's also a bit drug dependent. Here's where ticagrelor is a little bit advantageous because it's more rapid off. So, you have the potential, if the surgeon insists on it being off, you have the potential to get there quicker with ticagrelor than you would with clopidogrel. So, again, it takes several days. So the 3 days is 3 to 4 days for clopidogrel is probably enough. 2 days for ticagrelor is probably enough. But again, it's probably not that important. A bunch of observational studies have shown that you can safely do surgery on dual antiplatelet therapy. They're just observational studies. We don't have randomized trials in that setting. And then your question about after. So again, there's really no great data on this, right? Because you can do the surgery safely on it, then of course there's a range of when you might start safely afterwards. So if it's an uncomplicated surgery, I would restart. I should answer that part of your question. I would, because they remain at high risk, even though the stenosis is fixed, they're still at quite high risk for a while. So I still would do it. And again, I think it's arbitrary, honestly. A couple of days is not unreasonable.
Great. Yeah, I agree. It's certainly surgeon dependent on the issue of operating on dual therapy. We do have one of our more prominent surgeons who really thinks there's a lot more bleeding with an endarterectomy on dual therapy. So if we know that's where we're headed, we may be a little more conservative. But often at the time you're going to start this, you're trying to get it in as quickly as possible. You may not even know that this is a patient for endarterectomy.
Yeah.
You want to pick the next one, Clay?
Yeah. I think this is a real quick one, but just any drug interactions to be cautious of.
Yeah, no, that's a good question. I mean, obviously the antithrombotic or thrombolytic agents are obvious. I think maybe what the questioner is getting into is that there is some evidence that ticagrelor can increase the serum concentrations of some of the statin agents. So some people are a little bit more cautious with statin doses in ticagrelor patients. And for clopidogrel, probably the more talked about interaction is the omeprazole perilosec, which may decrease the serum concentrations of the active metabolites of clopidogrel. So those are the things that come to mind for me. Any others that you think of?
No, those are right. I mean, we had some concerns about those agents for the trials, no surprise. But honestly, it wasn't an issue. And ultimately, we decided not to worry about any of those drugs. Didn't see any real evidence that they matter. Just the anticoagulants, obviously, other antiplatelet agents, those matter. But beyond that, we didn't see any real impact of the other classes of drugs that you mentioned.
Yeah, terrific. So next question has to do with the duration of treatment. And obviously we talked about the 21 to 30 days, but I think what the questioner is getting at is, what if you've got somebody who's really got a lot of risk factors? They've got diabetes, or they've got chronic kidney disease, or they're elderly. Do you stretch those limits? And do you go longer for some patients and shorter for others?
No, because I just don't think we have the evidence. The longer it's not as though, I mean, it's actually a good question. If somebody wants to look at this and point, you can't look at it in chance because all treatment was stopped at 21 days. You can't look at it Talus because all treatment was stopped at 30 days. But of course, in Point, we had 90-day dual antiplatelet therapy. And we honestly did not look at that question. Is there a subgroup that particularly benefited between 21 days and 90 days? And it's a fair question. So, again, that data set is available publicly, and a lot of people are looking at it. That's a fine question to ask. But right now, a priori, I don't have any reason to expect that group would either differentially benefit or be at risk from dual antiplatelet therapy beyond that 21 days.
Great. I agree. Let's see, you want to pick the next one?
Yeah. Let's talk a little bit about drug failures. There's some questions about that. Does that change your decision if a patient comes in on aspirin or comes in on clopidogrel about what you would use?
Yeah, we addressed a little bit about that. I always see this as a high-risk patient. We learned that way back in the WARS trial. Those who came in and were taking warfarin had much higher risk of recurrent event, although their response to warfarin versus aspirin didn't differ. So what I'm thinking about for those patients is what risk factors can I control? Do I have their treatable risk factors under control? And is there something else going on? Could this be somebody who's got a condition that really should be treated with an anticoagulant rather than an antiplatelet therapy? And am I missing that? Is this somebody with antiphospholipid antibody syndrome, or they've got paroxysmal atrial fibrillation or a hypercoagulable state? But if I don't find that, I'm going to just go to the standard. I'm going to not worry so much about the agent that they chose. If they're a candidate for dual therapy, I'll go with dual therapy. From a psychological point of view, if you were on clopidogrel and aspirin, people often don't want to go back to what you failed. So it is wonderful to have more alternatives, and that may be somebody you'd be more anxious to go with the ticagrelor. And I think there was a question about what if you're not in the situation of dual therapy and you're failing clopidogrel? Is there a reason to go on ticagrelor? And you pointed out that that we didn't get a win in Socrates, but we came awfully close. The single ticagrelor versus aspirin, if you looked at the endpoint of ischemic stroke, it was statistically significant. All the endpoints went in the right direction. If you looked at some of the subgroup papers, like those with atherosclerosis, they had a statistically significant benefit. So personally, I don't have an issue going with ticagrelor on its own in somebody who's failed clopidogrel and is looking for another alternative. What do you think?
Yeah. I mean, I of course, it's not approved for that indication, and just as you pointed out, Socrates really is a negative trial. On the other hand, I mean, just treatment effect was actually greater there in Socrates than in Capri. A longer duration of follow-up, obviously, in Capri, the trial that we used to justify clopidogrel alone for long-term treatment. So I don't think that's unreasonable at all, particularly in somebody that you have concerns about, a CYP2C19 polymorphism that would limit clopidogrel's effectiveness. Hey, Carmine, how are we doing on time? Do you have questions there that you want to go to, or should I ask Greg another couple?
I think you can ask one more question, and then maybe we'll take one more here, and then that should bring us to time, I think.
Okay. So Greg, this question of what to do after TPA or thrombectomy, do you ever use dual antiplatelet therapy in that setting?
Yeah, it's a great question. There was a trial, European trial years ago that asked the question, do we really need this 24-hour window? Can we start the antiplatelet therapy within that 24-hour window? And it got stopped early because there was too much hemorrhage. So we don't break the rules about, holding the antithrombotic therapy for 24 hours after TNK or alteplase. But then, the question is, what do you do after that? right? If this patient really is somebody in a high risk category, who would, presumably be at very high risk because of severe atherosclerosis, multiple events, et cetera, we would consider the dual antiplatelet therapy for 2-3 weeks. However, of course, these are patients who would not have made it into these trials, right? The patients who received thrombolytics, they would not have made it. So we don't have the evidence-based data. So again, it's judgment. And I'll say in general, we're just using a single antiplatelet therapy in those settings. How about you, Clay?
Yeah, same for us, Greg. I mean, I agree with you, though. It's a really high-risk group. We did a study looking at the patients enrolled in the original TPA trial, and the risk of further deterioration due to ischemia is actually quite high, even higher than in this general group that we studied in all these trials that we've just been discussing. So the risk of recurrent ischemia is quite high. They're likely to benefit from pronounced antiplatelet therapy, just like in the coronary beds, right? So I bet it works. But just as you said, no evidence from clinical trials right now. They were excluded because of concerns about hemorrhage. That'll be the next trial, but it'll be a hard one to do.
Yeah. All right, Carmine, do we have some local questions there from the New Orleans crowd?
Yes, we do. We have one that might be quick, and then one that brings us full circle, I think, and it's a great one to end on. So one quick question on ticagrelor. You brought up the breathlessness, and the question is that dose dependent in your experience?
So we usually have just been stuck with a single dose. Our trials use the 90 BID. So I don't know. The cardiac folks might know. Clay, do you have any further insight on that?
No, single dose, so don't have experience on it. I mean, I'll tell you, it generally just goes away. So, just riding it out is usually the best approach. And I realize with dipyridamole, we got used to reducing dose and then pushing through and all that. It's not like that. It's not as nasty as the headaches were with dipyridamole, or as persistent. So it ended up really not being an issue in the stroke trials.
Okay, there we go. And then the last question, I think, brings us full circle. This refers to the first case, I think, that you presented, the case of Eleanor. And the question is, what agent would you continue Eleanor on after 3 weeks of dual antiplatelet therapy?
Want to start on that one, Clay?
For me, it's still aspirin. There's the strongest data, long-term uses for aspirin. I realize there's some concerns about aspirin's impact waning over time, but the data don't really suggest that that's the case. It continues to be a benefit, weeks to months after an acute event. It's cheap, it's easy. You can miss a day, and that's no disaster. So it would still be aspirin, 81 milligrams.
Yeah, I think it's dealer's choice, and certainly the guidelines would support that one could go, either with aspirin or clopidogrel in that situation. One of the questions that we didn't get to was a couple of different questions about if you're going with aspirin, are you going to use the enteric-coated versus non-enteric coated? And certainly there have been some mixed results of studies on this where there's lower bioavailability of these enteric-coated. They're not absorbed as well in the higher pH environment of the small intestine than that you're trying to protect the stomach. So I think that's one of the considerations. If you're going with aspirin, do you want to lean towards a non-enteric coated formulation that might provide a little bit more efficacy? Again, the jury's not completely in on that. But also, I don't think clopidogrel is an unreasonable opportunity. You go back, to the Capri trial where you had 6,000 stroke patients going long-term clopidogrel head-to-head versus aspirin, and although the results weren't statistically different in those patients, they certainly were compatible with the overall results of the study, showing a very mild benefit of clopidogrel over aspirin. And in terms of the side effect profile, there was less GI bleeding, there's less gastric irritation from the clopidogrel. So again, particularly if it's somebody who we're worried about, they've had previous gastritis, GI bleeding issue, that might be a reason that I would lean to the clopidogrel monotherapy in Eleanor's longer-term state.
All right, thank you. So I think we could probably close, but do you have any final closing thoughts before we end the evening for the audience?
I mean, for me, thank you all for coming, and enjoy New Orleans or your evening at home, and just remember, I mean, I think we're horribly underutilizing dual antiplatelet therapy right now. We probably need to study it more closely, but I think there are many people who would have been enrolled in these trials who now evidence suggests strongly that they should be treated with dual antiplatelet therapy. Guidelines now support it, who are not getting treated. So please look at that in your practice and the practices around your town, and let's all try to work together to improve the outcomes for patients.
Yeah, absolutely. I agree. It really a shame not to have us all live and in person together to enjoy New Orleans and to be able to have in-person conversations about this. But it's great to see the tremendous interest and the very sophisticated questions that are coming in from the audience. And I'd just like to point out again that not only are we underutilizing the agents, but oftentimes the patients aren't taking the therapies, and it holds not only for the antiplatelets, but really getting the blood pressure and the other risk factors under control has such a huge impact on reducing the risk of stroke. So I think it's something that all of us can work even harder on our practices. But pleasure to participate, and hope to see everybody next year.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SPE860. This activity is supported by an independent educational grant from AstraZeneca LP. This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.